I'm happy to present our next speaker, Dr. Eric Esrailian. I've had the pleasure of knowing Dr. Esrailian since I was a resident in internal medicine. Dr. Esrailian completed his gastroenterology fellowship here at UCLA, where he also obtained his master's degree in public health. He then became full faculty here at UCLA and continued to demonstrate excellence, dedication, and commitment to our division. In just a short time, he became the co-chief of our Division of Digestive Diseases here at UCLA. He has also been awarded the Lindsay Foundation Chair in Clinical Gastroenterology by the UCLA School of Medicine. His clinical interests in gastroenterology are broad and include inflammatory bowel disease and functional gastrointestinal diseases, and he has a particular interest in the development of biomedical innovations, value in healthcare, and initiatives towards patient-centered care. Today, he will be speaking to us on the exciting and emerging topic of fecal microbial transplant. Welcome, Dr. Esrailian.
Thank you, Mary, and thank you to all of you for spending your weekend with us. I just want to give a particular thank you to Tricia James for her excellent organization of this conference, and Bennett Roth and Raman Muthusamy, who are the real true course directors. I've just kind of been hovering in the background trying to help when necessary, but they deserve a round of applause, please, before we get into it. And they've done an amazing job. So, as Mary said, I'm excited to talk about this topic because I think it's relevant for many of our practices. It's relevant for the scientific literature. But before I do, I just want to again say thank you for spending time with us this weekend. As Dr. Gitnick mentioned on Friday, the division has an illustrious history thanks to the initial beginnings with Dr. Mellenkopf. So it's an honor for us to be here and celebrate education and gastroenterology with all of you. So what I'm going to focus this talk on, besides just fecal microbial transplantation, is a general microbiome 101, because as many of you who read the literature have seen, there's a constant repetition in terms of the terminology of the microbiome. There's a lot of excitement about the potential of the microbiome, not only in gastrointestinal diseases, but in other conditions. And so I think it's important just to kind of summarize where the literature is in the microbiome. And then we'll do a fecal microbial transplantation 101. We'll speak a little bit about a common enemy, Clostridium difficile infection, and we'll talk about possible applications of FMT beyond C. diff. So microbiome is kind of a word that you'll see thrown around, and it might mean different things to different people. Essentially, the broad categories of microorganisms that comprise the microbiome are bacteria, archaea, microeukaryocytes, and viruses. And when the collective genome of these microorganisms is also considered, the term microbiome will be used. But oftentimes, the terms microbiota and microbiome are used interchangeably. So for decades, we had limitations in terms of identifying what comprised the microbiome based on what scientists were able to actually grow in their laboratories. But now, because of our analytical capabilities, scientists are able to dig in deeper in terms of these characteristics of the microbiome, and that's where our knowledge has really exploded in the last 5 years. We really focus now in terms of what the benefits are potentially, or the impact of the microbiome on health, disease, and wellness, and potential therapeutics for different conditions. So again, oftentimes the ability to characterize a microbiome has been limited to just looking at the taxonomy, but now the quality, so to speak, of the microbiome is also being evaluated. Is there a difference in terms of having a different number of microorganisms, the balance, the richness of the microbiome, and there's also going to be research conducted in the near future in terms of trying to grade the quality of one's microbiome, similar to blood pressure and other types of values that we use in patient care. So using RNA sequencing and DNA sequencing, there's been an explosion in terms of our ability to understand what is within an individual, what is within an individual patient. And the greater richness of diversity, again, can vary depending on the different types of microbiota, the comparisons of microbiota between organisms, and basically how much of this is actually an indicator of one's health. So this is a schematic that you actually have in your syllabus, and it just is a general kind of summary of how the microbiome are analyzed within individuals using DNA sequencing, RNA sequencing, and big data analytics. Scientists are able to compare what's within the microbiome with known, basically different types of different types of genetic analysis that are already known, and you can cross-reference within an individual patient and see, is this patient's microbiome more diverse or less diverse compared to another. So in the scientific world now, you see an explosion in terms of what is discussed in the literature. And essentially, in the last 5 years, about 90% of the references for microbiome are evident in PubMed. And prior to that, you basically would have a limited exposure to different types of data. And basically, the American Gastroenterological Association now has established a center for the gut microbiome research and education. And I've actually listed the link in your syllabus. And really, the mission is to advance research, education in the gut microbiome, and human health and disease. And we're excited that you're here with us this weekend because there's also the third Gut Microbiome Health World Summit, March, excuse me, is this weekend as well. Sorry, I lost my train of thought for a second. So now there's also a broad public interest in the microbiome. And these books are actually available for you on Amazon.com. Poop Power, as well as the Fecal Transplant Guidebook. And it is a humorous topic, but realistically, this is actually something that our patients are going to bring to us when you see them in the office. So today's patients are basically more informed than ever before. They've already seen Dr. Google, and essentially, we are now the second opinion. So there's going to be many questions out there in terms of what your patients are going to ask you. Are they candidates for fecal microbial transplantation? Should they be taking probiotics? Do they have to take a probiotic with an antibiotic? And we're really, as physicians, never going to have all of the answers, but essentially we're always going to try. And I think the more we know about this topic over the next few years, the more we're going to be able to better help our patients. So really, what is special about the gut? Essentially, Chris Chang, who's now at Cedars-Sinai, always told me that basically we're more bacterial than we are human. And the gut is really home to a multiple trillions of microbiota, and we have more bacterial cells in our body than human cells. So we outnumber, basically bacterial cells outnumber human cells by 10-fold, and the human genome is outnumbered by 150-fold. So you can understand why there's such scientific interest, because this is really the great unknown. And the more we can understand this, the more potential we have to treat conditions that have otherwise been basically stagnant. So if you're a fan of Gary Larson like I am, you'll see that he used to have a lot of cartoons about amoeba and other types of organisms. And these amoeba are basically using the old methodology of just looking at it under the microscope and seeing if something is healthy or not. So these amoeba are looking at the square amoeba and saying, that guy looks sick. So we've gone a long way since Gary Larson days now of using the 16S and 18S RNA sequencing and DNA sequencing to actually quantify and describe what the microbiome are. So essentially, we have a love connection with our microbiome. We don't need to go on an internet dating website. We've co-evolved to basically exist with our gut microbiome in a mutually beneficial way. We as hosts rely on these organisms for key function, like our nutrition, defenses against basically pathologic species, and we provide the gut microbiota with a unique milieu for survival and nutrition. And the mucus basically secreted by our intestinal epithelia actually are a perfect petri dish, so to speak, for these organisms. And that's one of the reasons why we have to be careful, as Dr. Islam mentioned, in terms of using antimicrobials in a haphazard fashion. So dysbiosis essentially is another term you'll see a lot in the literature. and it really relates to an alteration in the microbiota associated with disease. And this has been described particularly in gastroenterology in many conditions: inflammatory bowel diseases, functional GI disorders, cancer, metabolic diseases such as diabetes and obesity, and of course, Clostridium difficile infection. So dysbiosis is really the impetus for our evaluation of FMT. And it would be ideal if we could demonstrate that if we killed a huge percentage of flora in our gut and then developed some sort of infection, subsequently we're able to reinstitute healthy bacteria into the gut and cure that infection, that there could be a one-to-one correlation. This hasn't really been shown consistently in other diseases, but it has in Clostridium difficile infection. And so if there's one take-home point that I'll try to get across when we're talking about FMT, is that in recurrent Clostridium difficile infection, fecal microbial transplantation can be an effective treatment. And ultimately, when we transplant huge amounts of bacteria into a host, that's considered fecal microbial transplantation and FMT. So you often hear that terminology interchangeably. So FMT, again, if this is the one take-home slide that I want you to think about, is highly effective in the treatment of refractory Clostridium difficile infection. Basically, the fecal microbiota have been administered via enema, colonoscopy, nasogastric tube, nasoduodenal tube, or nasojejunal tube. And Dr. Tillich is going to be talking about probiotics, but the World Health Organization essentially defines probiotics as live microorganisms which have been administered in adequate amounts that confer a health benefit. And FMT entails a transfer of entire communities, essentially in the same relative abundance that would be seen in a healthy host. So in 2013, there was a lot of talk in the literature about FMT because of the possibility of requiring an investigational new drug application. And there was a multi-society and multi-specialty set of guidelines that were published in all of the major journals, and essentially identifying preferred donors and listing potential donor exclusion criteria. And I have references provided for you in their syllabus. Essentially, the serologic testing is conducted to rule out bloodborne pathogens, and stool testing is conducted to rule out other pathogens that are essentially relevant to the clinical condition. So of course, Clostridium difficile infection, if a patient has had a recent travel history, potentially ova and parasite as well. So FMT has essentially been successful for recurrent C. difficile infection, and the treatment has been conducted in various locations. So in the literature, there are studies showing home enema therapy. There are infusions that have been conducted in the hospital, and there are infusions that have been conducted in the endoscopy units. In our experience at UCLA, we've essentially done the home therapy route and the endoscopy unit route, but to my knowledge, there hasn't been any FMT conducted in the hospital to date. Now, the freshness of the stool may not matter. You'll see in the guidelines that oftentimes stool specimen has been recommended to be collected within 6 hours of transplantation, but there are many documented effective transplants that have been conducted with frozen stool, and there's commercial applications under evaluation with frozen stool. So ultimately, we know that freshness may not matter, but this is part of the current guidelines. The stool preparation has been described using blender, and Tom Liu at Beth Israel Deaconess and Kieran Kelly taught me about how to use a potato ricer, which I'll show you a picture of what a potato ricer actually is. But you can imagine that using a blender could be particularly messy, especially if you're going to be doing this in a hospital setting. Stool is prepared. Roughly 50 grams of stool has been recommended, mixed in with 250 to 500 cc's of normal saline. So kind of a slurry is created. And the route of administration, as I mentioned, has been used with colonoscopy, enema, or using infusions from the proximal gut. So via colonoscopy, it intuitively makes a lot of sense. We have a sense of control in terms of the administration and the distribution of the transplanted material throughout the gut. So this is a potato ricer, which you can actually find at any Bed Bath & Beyond or kitchen supply store. And as you can imagine, there's more control in terms of preparing the slurry as opposed to using a blender. And again, Tom Liu at Beth Israel Deaconess is the one that told me about this. So this is the take-home slide really for FMT, the summary of the data. The systematic reviews of multiple studies that are in the literature suggest that there's a resolution for recurrent C. difficile infection of roughly 90%, sometimes even higher than that. So that's kind of the general number for your clinical practice and boards. In 2013, there was an RCT published in the New England Journal of Medicine showing that duodenal infusion was superior to vancomycin treatment in patients with recurrent CDI. And as many of you know, taking care of patients with Clostridium difficile infection, it's particularly burdensome for them to take antibiotic rounds after antibiotic rounds, extremely costly, and some of these drugs are very difficult to tolerate. And as soon as the patients start to taper off, they start to feel worse. And ultimately, some patients obviously have severe morbidity and potentially even mortality associated with CDI, and there's a lot of information in the literature about success, again, over 90% roughly in patients who have received FMT for this purpose. So the summary is that it's relatively safe. We can talk about what are potential risks, but ultimately they're related to the risks of infection. If there's some sort of mistake in terms of the screening and patients were, infection was transmitted using FMT, or injury during the method of administration. So if there was a colonoscopy performed and there was some sort of complication related to the colonoscopy. But again, in terms of adverse events, extremely few episodes of adverse events in the literature, and the long-term data is what is lacking. So a big question clinically is, do I need an IND for FMT? So an IND is an investigational new drug application. And the FDA is essentially charged with the oversight of substances that potentially can prevent, treat, or cure a disease. So it makes sense that the FDA is involved with this process. But when there was a brief period of time when an IND was required, it essentially shut down FMT throughout the country. So many patients were not able to get this treatment, where in the community there had been, and in universities, there had been this treatment going on for quite some time. And the reason is because an IND is extremely complicated. It's time-consuming. There's a lot of paperwork involved, and the average practicing physician is not going to be able to go through that entire process just for an individual patient. So right now, the FDA is not requiring an IND, so that's the take-home message from that standpoint, for the treatment of refractory C. difficile infection. That's specifically that, as long as an adequate informed consent is obtained. Now, while the IND is still encouraged, as long as you get an informed consent and document potential risks, benefits, and alternatives, the FDA will allow FMT to be conducted. At a minimum, there should be some sort of statement saying that the use of FMT is investigational and that you've discussed those risks. And then this discretion will essentially be in place until the FDA issues new policies. So this is one area that is very complicated, which is the billing and coding for FMT and reimbursement. And this is really a black box and sometimes can be a barrier for both patients and clinicians going the FMT route. There are guidelines that there is a link in the syllabus to the AGA website in terms of guidelines for billing and coding for practitioners. The main issue is that the donor testing is often not covered by insurance. So that process can be very costly, and going through that with patients sometimes can be essentially cost prohibitive. But again, if you factor in the costs associated with ongoing antibiotic therapy and the comorbidity of having both the infection and hospitalizations and all the other complications associated with hospitalizations, it may make sense for an individual patient. But this is a discussion that oftentimes can make FMT not seem like a worthwhile exercise. Medicare does not cover the cost of screening, and oftentimes if a patient needs a colonoscopy for diarrhea, for example, that can be worked into the billing for that procedure. So what about other GI conditions? And the main issue is that C. difficile infection is a very discrete thing that we can evaluate clinically. Patients are sick, they get a treatment, they feel better. In experimental studies looking at IBD or irritable bowel syndrome, basically in rats, for example, there's a monophasic disease. You give a chemical drug, you basically induce colitis, treat the colitis, or not. In humans, basically patients have waxing and waning courses of irritable bowel syndrome or inflammatory bowel diseases, which makes it much more difficult to evaluate the use of FMT in these patients. The heterogeneity, for example, in inflammatory bowel disease is consistent with the heterogeneity we see in treatments. Sometimes using antimicrobials is helpful for perianal disease. It is not so helpful for patients with small bowel diseases. So that makes these conditions much more challenging when evaluating FMT. Unlike in CDI, there have been many uncontrolled studies and case series looking at both irritable bowel syndrome and inflammatory bowel disease. In IBD meta-analyses suggest potential impact of FMT in patients with ulcerative colitis, but again, the data is not as robust as we have seen in CDI, which is one of the reasons why an IND is required if you're going to use FMT for anything other than recurrent CDI. The maximal benefits have been seen in ulcerative colitis, as I mentioned, outside of CDI, and as Dr. Tillich will mention when she's talking about probiotics, there are a huge number of studies which are essentially heterogeneous case series, anecdotal studies that really don't make it easy for us to try to apply FMT in other areas yet. However, one of the exciting areas of the microbiome is looking at FMT potentially in other conditions, such as cardiovascular diseases, obesity, and autoimmune diseases. So essentially, the microbiome is really the next frontier. This is an area of science that has exploded. There's going to be much more study and evaluation in the literature in the coming years, and I think our explanation for why we have certain conditions might be better informed after we have a better understanding of this. There are some causal relationships with changes in the gut microbiome and human diseases. FMT is effective in treating refractory CDI and may be the most effective treatment we have for refractory CDI, and you do not need an IND if you're going to be doing this. Just make sure you get an informed consent. There are plenty of resources available in the syllabus, and as I mentioned in the future, the role of FMT in other diseases has yet to be determined. Thank you very much.